Hi everyone, welcome to today's webinar. We'll let a few others join here. So it's right at noon Mountain Time currently, but we'll give everyone another minute or two. All right. Well, I think we'll get started here shortly, Ashley. So, just wanted to welcome everybody to today's webinar. My name is Avash Kalra. I'm the course director for our hepatology and liver transplant webinar series. Really appreciate all of you joining today. And I suppose some of you may be watching this in the future on the video, since we will post this on our webinar website as well. I'll just say right off the bat that we have a really great series of talks this year, and the whole schedule is listed on the website for this course. And today's talk is given by Dr. Lane, colleague of mine, and she is an assistant professor of medicine and transplant hepatology here at the University of Colorado, and also jointly appointed at our VA Medical Center on the other end of our large medical campus here in Aurora as well. So Dr. Lane's going to be talking about updates in the management of hepatocellular carcinoma, and really appreciate her time, and she'll go through her talk as well as give some information about CME, which is offered free from this talk as well. So Dr. Lane, thanks for joining us and giving the talk today.
Thanks, Dr. Kalra. Hello, everyone. Good afternoon. And Dr. Kalra, thanks for the opportunity to present this to y'all today. So like you said, I'm going to be talking about the updates in the management of hepatocellular carcinoma. So here's a brief slide on CME accreditation, how you can go and claim your CME credit for this presentation. I have no relevant financial relationships to disclose. And then here also how to reach evaluations and CME certificates after. So if you go to this link and SurveyMonkey, you can request your CME and CME certificates. All right, and just a brief slide for the College of Nursing and Professional Development disclosures. So how you can go on and get your contact hour for this completion of the course as well. All right, so let's get to the meat of the talk. So my goals for everyone today, so you guys are going to be many experts on surveilling, diagnosing, and managing patients for HCC. So I want you guys to become comfortable at identifying patients who are at risk for hepatocellular carcinoma or HCC. We're going to discuss tools used to screen for this and also diagnose it. And then we're going to review the multidisciplinary management of HCC and then the role of liver transplantation as well. So why is this important? So HCC is the most common primary tumor of the liver. So it's the sixth most common cancer and third leading cause of cancer-related deaths, not only in the US, but worldwide. So a big issue. Untreated, the prognosis remains poor. So 5-year survival is about 18%. And then, of course, as hepatologists, we obviously really care about this. So who is at risk for HCC? So the biggest risk factor for developing HCC is cirrhosis or end-stage scarring of the liver. So the majority of patients diagnosed with HCC have cirrhosis, over 80%. And then patients who have cirrhosis have an average annual risk of developing HCC of about 2%, although range, depending on what caused their liver disease, is 1 to 8%. Other risk factors for developing HCC that compound on top of that as well. So alcohol use, that increases the risk as much as 5-fold. Metabolic dysfunction associated steatotic liver disease is a leading growing cause of HCC and those being considered for transplant. So that's MASLD. So we know that obesity is actually associated with a 1.5 to 4.5 times higher risk. Patients with chronic viral hepatitis, so hepatitis B and hepatitis C, those still remain predominant risk factors in many parts of the world. And then other things, so smoking, dietary exposures like aflatoxin B1, et cetera, are also risk factors. But of all these, cirrhosis is the biggest one to know. So I thought it'd just be interesting to show you guys the global incidence of HCC. So the darker the blue color, the higher the incidence. And then the little wheels next to the countries and regions are breaking down the etiology of the chronic liver disease that led to HCC. So you can see the United States has one of the higher incidence rates of HCC. And then of those patients, as of right now, who have HCC, the biggest risk factor still is viral hepatitis, so hepatitis C. But other etiologies are fastly catching up, such as MASLD. So taking a step back, how can we prevent HCC? So really comes down to implementing evidence-based recommendations and managing chronic liver disease and screening for HCC and having public health policies. So specific examples are someone with chronic hepatitis, so hepatitis B and hep C. If they have indications for treatment for hep B, treat hepatitis C. Vaccination for hepatitis B should be given to all newborns and high-risk adults who were not vaccinated previously. It's important to counsel on a healthy lifestyle, so not only for liver health, but overall global health. So things like maintaining a healthy weight, avoiding alcohol and tobacco, managing metabolic comorbidities are very important. Coffee consumption, there's some data showing it can lower the risk of HCC in a dose-dependent manner. So we do encourage coffee drinking in our patients. Caffeinated coffee has the biggest effect, caffeinated drip coffee, but decaffeinated coffee also has a similar improvement. Chemopreventive agents require further study. Not currently recommended, although there is some evidence of risk reduction, but not currently recommended. So screening, as you can imagine, is extremely important. We want to detect HCC early so that we can treat and cure it and improve outcomes. And we know that patients who we detect HCC and manage it appropriately, their 5-year survival is over 70%. So things we think about when we determine if someone should be screened or not are their severity of underlying liver disease, what comorbidities do they have, what's their HCC risk, and then patient preferences as well. So we always say those at risk should be entered into HCC surveillance programs, provided they would be candidates for treatment. So the box to the right, the top part is those who have sufficient risk to warrant imaging surveillance. So those are patients with cirrhosis from any etiology. You notice patients with more advanced liver disease, so those child PUC patients, we typically only screen if they're going to be a transplant candidate. just because we'll talk about later, if they're very decompensated with significant comorbidities, there might not be a benefit to treatment and further management unless they're a transplant candidate. Also, patients with chronic hepatitis B, even if they're not cirrhotic. And then there's different risk stratifications the guidelines suggest based on those patients with chronic hepatitis B. So breaking it down to their male or female, their age, whether they came from Africa. So that's a very endemic country. Do they have a family history of HCC? Do they have hepatitis D co-infection, with which compounds that risk? And then there are risk calculators. So the page B risk calculator for those on antiviral treatment can predict the risk of HCC, but it's not widely used at this point. So those in which insufficient risk is there to warrant surveillance. So hepatitis C with stage 3 fibrosis, so advanced fibrosis, but not cirrhosis, and non-cirrhotic MASLD. Right now, the guidelines suggest imaging should not be pursued. So what imaging tests or what tests do we do to help screen for HCC? So the current guidelines suggest using ultrasound with alpha fetoprotein or AFP every 6 months. There really isn't enough literature right now on the efficacy, cost effectiveness, and safety of CT and MRI scans. Although limited data so far suggests MRI is more effective at detecting HCC with lower false positive rates compared to ultrasound. And there are actually a bunch of trials going on looking at abbreviated MRIs. So MRIs that have a lower scan time, minimize contrast exposure, are lower cost, comparing that to the standard of care as well. So stay tuned. So I put in this table to kind of walk you through how we generally think about what to do with imaging results once we obtain them and how we continue to surveil these at-risk patients. So if you're getting these ultrasounds and AFPs every 6 months and on the scan there's no lesion, it was good visualization, their AFP is normal, you keep them on that 6-month plan. If you image them and the visibility, there's moderate limitations, or if you find a really small lesion, less than a centimeter, but AFP is normal, they recommend close interval surveillance, so repeating an ultrasound in 3 to 6 months. If the visibility is very impaired, so there's severe limitations, obviously it's not a good test for screening. So that's when you want to get a CT or contrast enhanced MRI to screen adequately. And then of course, if you see a significant lesion, so a lesion greater than or equal to a centimeter ultrasound, the AFP is elevated or the AFP is progressively increasing, that's when you want to get the multiphasic CT or contrast enhanced MRI. So bottom line is those patients at risk for HCC should be getting imaging plus an AFP every 6 months. So how do we diagnose HCC? So those at-risk patients that we're screening, so those with cirrhosis or chronic hepatitis B, majority of the time we should be making the diagnosis on non-invasive imaging criteria. And then sometimes we do need to biopsy for those that we're really concerned, but imaging is non-diagnostic. And this should be made on contrast enhanced MRI or multiphasic CT. So ultrasounds are not sufficient for diagnosis, and we'll talk about why that is. Biomarkers, so the AFP is helpful and adjunct to diagnosing and monitoring patients with HCC, but it shouldn't be the sole thing you look at to diagnose it. And then those patients, so say you have a patient who isn't an at-risk patient, so a patient who isn't cirrhotic or has chronic hepatitis B, technically if they have a liver lesion, they should undergo a liver biopsy to confirm the diagnosis. Okay, so imaging characteristics of HCC, how we diagnose it non-invasively. It's pretty interesting. So we have pretty specific criteria to establish the diagnosis in those at-risk patients. So we know that HCC has characteristic features on imaging, which is how we can diagnose it on imaging. So it's really important when you get imaging, especially the contrast enhanced CTs, that you get what's called multiphasic imaging. So that means you get multiple phases. So you need an arterial phase, a portal venous phase, a delayed phase, and typically they get a non-contrast, just baseline scan as well. But you really need at least 3 phases to diagnose. And that's because the lesions light up in a particular way. So here's one of my patients at the VA who was diagnosed with HCC. So the image in the top left, that is a non-contrast, just baseline scan. And even on that sequence, you can see the red arrows pointing to something that looks suspicious. In the top right, that's the arterial phase. So the lesion enhances on the arterial phase. It looks brighter compared to the background liver. And the bottom left, that's the portal venous phase. So characteristically HCC lesions will wash out on the venous phase. So the lesion will get rid of that contrast. It should look darker than the background liver. And then the bottom right, there is a delayed phase, a 3-minute delay. So occasionally these lesions on the delayed phase will show a pseudocapsule, enhancing pseudocapsule, which this does. So this lesion is characteristic of HCC diagnostic scan. You may see, I just included in the top right, nothing for you to memorize, but you may see our radiologists use what's called the LIRADS criteria to risk stratify lesions, see if they meet certain criteria that help us characterize the lesions and determine our concern for HCC or not. Okay, so we have a patient that we've diagnosed HCC in. So what do we do next? How do we stage it to get the ball rolling and managing them? So in addition to good quality imaging of the liver, so CT or MRI, a CT of the chest is generally advised if the tumor is greater than or equal to 2 centimeters, just to make sure there's no metastatic disease. You'll see us sometimes getting other imaging like pelvic imaging or bone scans if the AFP is significantly elevated, looking for extrahepatic disease. PET scans, we generally don't advise or obtain. They have a really low sensitivity for HCC. And then for staging, there's no universally accepted staging system, but you'll sometimes see, like in the guidelines or for clinical trials, they'll use the Barcelona Clinic liver cancer prognostic stratification based staging, which I'll briefly reference throughout the talk. But it basically stages malignancy from 0, which is very early disease, and then A through D, which is early to advanced and terminal disease. So early stage disease, the expected survival is over 5 years. Intermediate stage disease, the anticipated survival is over 2.5 years. And for advanced stage disease, their expected survival is over 2 years. So when it comes to managing HCC, really a multidisciplinary based discussion is extremely important. So it allows us to individualize treatment approaches, and it can actually lead to improved patient satisfaction, receipt of curative treatments, decreases time to treatment, improves treatment outcomes, and patient survival. So you'll see us at the university take this approach on all our patients. So it's a group of providers who we have experts in radiology and other consultants in the field where we discuss our patients. And actually, a multidisciplinary approach can change interpretation of imaging in up to 20% of cases and can change treatment plans in up to 42% of patients. So really important. Things we think about when we think about individualizing a treatment approach. So we look at the patient's tumor burden, their AFP, their degree of liver dysfunction. Surrogate markers of that can be their MELD score and Child-Pugh score, the presence of portal hypertension or not, their performance status, and whether or not they're a candidate for liver transplant or not. All right, so let's delve into the different treatment options for HCC. So we'll talk about all of these, the things we think about. So surgical resection, local, regional, or liver-directed therapy, systemic therapies through our oncology colleagues, combination of all of those things, and transitions between the types of therapies. So surgical resection, it is the curative treatment of choice for localized HCC in those without cirrhosis. So that's about 10% of cases are those non-cirrhotic patients with localized HCC. We know that surgical resection in select patients, they have a lower post-op liver-related morbidity, lower cumulative recurrence rate, and then higher disease-specific survival. So we do sometimes think about surgical resection in very select patients with cirrhosis. So they need to have limited tumor burden, their liver disease is well compensated, and they don't have clinically significant portal hypertension. We know that outcomes are worse, so patients can develop decompensated liver disease and liver failure if they have clinically significant portal hypertension. And then it's important to take into account, not only with cirrhotics, but any patient, the planned extent of hepatectomy and how much liver remnant they will have left after the resection. So will they have enough liver remnant to keep them alive? Current literature doesn't support the use of neoadjuvant systemic therapy, but adjuvant therapy can be considered if they have a high risk of recurrence. And then just important to note, so preoperative local regional therapy like transarterial chemoembolization, which we'll talk about in large resectable HCC, doesn't improve recurrence-free survival. And then once someone has a surgical resection for HCC, we surveil them indefinitely, which we'll talk about as well. All right, so let's talk about local, regional, or liver-directed therapy. So when I talk about this, that means local ablative therapies, which are technically curative, and transarterial therapies as well. So local ablation, so that is where providers locally ablate the diseased tissue or the malignancy, and then a little bit of normal tissue or background cirrhotic liver. So we consider that in patients with very early or early stage HCC. So the guidelines suggest considering for those with a lesion less than 5 centimeters, although we know patients with tumors greater than 3 centimeters have a lower response rate and increased recurrence rate. We also think about it in those who are ineligible or decline surgical therapy. So we determine eligibility by their tumor size, location, whether or not we can achieve adequate ablation markers. So getting all that tumor and then a little bit of background liver as well. Lesions that are bigger than 3 centimeters, like I said, are located near structures where pursuing ablation that can hurt the surrounding structures. If there are critical structures around, we consider doing different modalities. So ablative therapies, when I talk about ablative therapies, what I'm talking about is typically radiofrequency ablation and microwave ablation. You'll see us sometimes doing cryoablation. The initial ablative modality was percutaneous ethanol injection, but it's really been replaced by radiofrequency and microwave ablation, and then the cryoablations due to superior response with fewer sessions. So we know that local ablative therapies actually have a similar survival rate compared to surgical resection in those with small lesions, so lesions less than 2 centimeters. And you can imagine patients would likely prefer to not be cut open and have surgery rather than just technically an outpatient procedure. So for thermal ablation, when I talk about that, I mean radiofrequency and microwave ablation. Those things are preferred, although there's no head-to-head showing superiority of one of those modalities over the other. So the overall survival and recurrence-free survival for those therapies are 76 and 46% respectively at 3 years for lesions less than or equal to 3 centimeters. You will sometimes see us combining that with transarterial therapies, which we'll talk about. So TACE to improve the efficacy in large lesions. So sometimes we do TACE followed by ablations to treat those cancers. So adverse effects aren't very common, but things that can happen are pain, fever, bleeding, infections like abscess, and then pleural effusions for our local reactive effect. The diaphragm's right there. All right, transarterial therapies. So what do I mean by that? So those are therapies that are delivered through the vessels feeding the tumors, which I'll talk about in a little bit. I'll show you guys pictures that deliver treatment right to the tumor through the arteries feeding the tumors. So the two specific types of transarterial therapies are chemoembolization, or TACE, or radial embolization, which is TARE. So this is the primary treatment option for intermediate disease. So in that staging system at stage B, you'll see us sometimes using it to downstage patients who are outside Milan criteria to get them in Milan criteria who are transplant eligible. And the choice of therapy, so TACE versus TARE, is really driven by the center expertise and the availability. So what can your local interventionalists do? What do they feel comfortable doing? I outlined on the right-hand side just some things we think about when we think about excluding factors or factors that make us concerned about doing these therapies. But we really do patient selection on a couple different things. So we like to maximize delivery of therapy just to the tumor, not other areas. So for TARE, things like lung shunts, and then other areas that the treatment might go, we like to rule those things out before doing, as you can imagine, so we don't hurt normal tissues. We like to minimize ischemic or radiation injury to the non-cancerous background liver. We take into account their degree of liver dysfunction. So will they be able to tolerate treatment, so treating the tumor, but also taking out a little bit of that background liver as well. So if they don't have decently functioning baseline liver status, then it could become an issue. We also take into account, obviously, their degree of tumor burden. Do we feel like we could adequately treat the tumor with local regional therapy without hurting them? And then do they have portal vein thrombus or not? So we know patients who have significant liver dysfunction, portal vein clots, large intrahepatic tumor burden have a lower chance of achieving objective response rates and have a higher risk of decompensation, although the established cutoffs for liver dysfunction or tumor burden haven't been well defined. All right, so let's break down the different types. So for chemoembolization, when I talk about that, you'll hear us talking about conventional chemoembolization or TACE. So that's Lipiodol TACE. And that is a radiopaque oil that actually is made from poppy seed oil and iodine that is used to emulsify and carry treatment, or DEB TACE. So DEB stands for drug-eluting beads that carries drug to the tumor. So between those two types of TACE, they have similar responses and safety profiles. So really, like I said, chemoembolization leverages the arterial blood supply of liver cancer. So HCC derives the majority of its blood supply from arteries compared to portal venous flow to the liver. So the majority of blood flow actually to the background liver is from the portal vein. So really, we know, just looking at overall response rates and median survivals, there's a significant improvement, as you can imagine, in those things compared to best supportive care. Adverse effects we can see, so we can get abnormal liver tests, fevers, bone marrow toxicity from the drug, pain, and vomiting. All right, so the radial embolization or TARE, so you'll sometimes refer to this as Y90. So that is basically injecting through the artery into the tumor beads, so a delivery system that has radiation on it, or Y90. So it's an accepted alternative for intermediate stage HCC. It actually was only recently FDA approved in 2021 based on the results of the Legacy trial. So that was a single arm retrospective analysis of 162 patients. They were well compensated. So Child-Pugh A with a solitary lesion up to 8 centimeters. So you can see the response rate was pretty significant, and the duration of response at over 6 months was 76%. There have been other trials since then showing significantly prolonged time to progression, but overall similar overall survival compared to TACE. And then more recently, there was the TRACE trial, which was a phase 2 trial comparing Y90 to DEB TACE and patients with early stage disease, and it showed improved time to progression, overall survival with TARE compared to DEB TACE with comparable safety profiles. So for right now, And as an alternative, you'll see some centers preferring this compared to TACE. So how do we assess response? So we assess response by surveillance imaging. So depending on what treatment they have and what their initial treatment burden or tumor burden was, we do imaging 6 to 12 weeks after the initial treatment. We tend to repeat treatment if needed, if there's viable disease, and then we continue to surveil them 3 to 6 months thereafter without viable disease. So those who have an objective response greater than 6 months, but then have local progression later on, their tumor biology is likely to respond to additional local regional therapy. So that's typically what we pursue. Those who fail to respond to initial treatment or progress after 1 to 2 sessions, we tend to consider them refractory, and that's when we should really be thinking about alternative therapies such as systemic therapy. Okay, so let's talk about some cases and I'll walk through what I'm talking about, TACE and TARE. So here's the first case. This is one of our VA patients. So they actually have a catwalk liver. So their left lobe actually dances across their abdomen and is abutting the spleen. But they have, oh, the arrow is kind of covering the top left, sorry. But on the top left, so that's a pre-TACE CT that shows an arterial enhancing lesion in segment 2. And our radiologist thought it was really difficult to target for ablation initially due to the spleen being right there and the bowel being overlying. So what they decided to do was conventional TACE with that Lipiodol to stain the lesion and initially treat it. So they did a doxorubicin Lipiodol emulsion. So with TACE, like I was saying, they typically cannulate the femoral artery. They go up and they identify the artery supplying the tumor. They inject this agent and do an angiogram to make sure they're there to light up the tumor. And then they inject the treatment, which for Lipiodol TACE is Lipiodol carrying that chemotherapy, that emulsion. So you can see that there. So in the top right, you see the lesion was stained and treated with the doxorubicin Lipiodol emulsion. And then following the TACE, those bottom 2 photos, the bottom left and the bottom middle. So it's a non-contrast CT following the TACE showing the lesion staying with Lipiodol. So Lipiodol will continue to light up after treatment. And then they ultimately decided to pursue ablation at the patient's wishes. So ablation is where they stick that probe into the lesion, and then they did microwave ablation. So they microwaved the lesion and burned it. So here's a second case. So in this case, this patient has more advanced disease. So they have multifocal HCC. So in the top left and the top middle, you'll see those lesions. That's an arterial phase scan, which showing the lesion lighting up, and the arrow is pointing to the lesions. So what they did for this patient was DEB TACE, so drug-eluting bead TACE. So they went in, you can see on the right, their angiogram. They identified the arteries feeding the tumor. They injected those drug-eluting beads with carrying the chemotherapy to treat the tumor, and then they embolized the lesion as well. So kind of a two-hit approach to treatment for embolization as well. So on the bottom, we have the follow-up scan 6 to 12 weeks later, and the arrows are pointing to the lesions that were treated that are no longer vascularized. So they're devascularized and have no enhancement, indicative of successful treatment. All right, so systemic therapies, let's transition to those. So systemic therapies and those with unresectable HCC who are unable to pursue liver-directed therapies or surgical resection, as I said. So those are more advanced stage patients, so the stage C patients. We sometimes think about doing in those intermediate stage patients, so stage B, if they have disease progression or contraindications for local regional therapy. So efficacy evaluated in select populations. We know it's highly efficacious in those with preserved liver function, so child PUA, and have good performance status. We don't routinely add local regional therapies to systemic therapy for those with advanced stage HCC, and it's technically not currently recommended. It has failed to show an improvement in overall survival, but you will see it done, and there are actually clinical trials ongoing looking at this. So this is a busy slide. I'm not going to go through everything, but I wanted everyone to be aware of the different options available to our patients through our oncology team. So there's two different groups of approved systemic therapies we like to think about. So there's the anti-angiogenic targeted therapy. So that includes the MTKI targeting agents and then also monoclonal anti-angiogenic antibodies. So sorafenib is the most well-known of the tyrosine kinase inhibitors. So it's a tyrosine kinase inhibitor targeting the VEGF receptor pathway and other kinases, and it was the first systemic therapy to demonstrate a survival and advantage versus placebo for patients with advanced HCC, and has since served as a control for multiple subsequent trials. But it really only showed a modest survival benefit about 3 months in those patients. But since then, you can see treatments options have bloomed. So now we have the availability of immune checkpoint inhibitors. Those can include inhibitors of programmed death 1 ligand, and then cytotoxic T lymphocyte associated protein 4 inhibitors. So in the top right, that just kind of outlines the different options we have now when they came available. And the resultant survival profiles, with the first line agents being on the top and the second line agents being on the bottom. So for those, we're thinking about doing systemic therapy with the guidance of our oncology colleagues. Sometimes they'll ask us to do an EGD to risk stratify for variceal or other GI bleeding risks. That's particularly with the first line therapies of atezolizumab and bevacizumab, just because they're known to work on the VEGF pathway and increase the risk of bleeding. So we do screen them. The ultimate optimal treatment of large varices prior to treatment is technically unknown. There's not enough data to support a specific pathway or not. But we tend to recommend at least one session of banding or the initiation of carvedilol for primary prophylaxis if we do find significant varices or evidence of clinically significant varices on endoscopy. In someone who's had recent bleeding, so bleeding within 6 months, or high-risk stigmata on endoscopy, so varices with red whale signs, they should have them adequately treated prior to considering therapy. So band ligation would be a good thing. So immune checkpoint inhibitors, a note on those. So we tend to not recommend them if they have moderate to severe autoimmune liver disease or in our post-transplant patients because of the high risk of graft loss and death in those patients. There is technically limited trials and literature to guide treatment for systemic treatment for those with more advanced liver disease, so Child-Pugh B. But you'll see oncology sometimes pursuing palliative therapy in well-selected patients who they think can tolerate after performing shared decision making. And then I included just a basic decision tree that was in the oncology-based guidelines, just kind of outlining the systemic therapy options and decision tree for using them. The risk of GI bleeding, do they have underlying contraindications, and kind of walking you through that as well. All right, so our bread and butter. So when do we think about liver transplant for the management of HCC? So we think about liver transplant in those patients who are transplant eligible if they have early stage liver cancer that is ineligible for resection. So those patients who have decompensated disease or clinically significant portal hypertension. So we'd be worried that they develop further decompensated liver disease and potentially die from those treatments. and HCC that recurs within Milan or transplant criteria after surgical resection. So we know that transplant not only cures HCC, but the underlying liver disease. And the median survival is very good. So it's 10 years. And there's a significantly lower risk of recurrence as well. So about a 10% risk of recurrence post-transplant versus 50 to 60% with the other therapies I talked about. As you know, the demand for organs far outweighs our supply. So, patients within transplant criteria who are eligible for an exception score waiting period, which I'll talk about, there is a risk of dropout as they're waiting for organs. But there is what's called exception points or an exception score. So those who were pursuing transplant they're going to get listed for a transplant. There is, after a 6-month waiting period, they get granted exception points that makes them competitive for a transplant on our list. So someone with a normal to low MELD who has HCC who otherwise wouldn't be competitive for transplant then becomes competitive with these exception points. There is strict imaging criteria and transplant criteria that we have to follow as well. So you will see us doing living donor liver transplants for select patients. It improves overall survival. It reduces the risk of waitlist dropout. And there's been shown excellent post-transplant survival in this group. So that has offloaded the burden. So when I talk about transplant criteria, you'll hear us mainly talk about the Milan criteria, but there's also the UCSF criteria, which also identifies patients who would be potentially suitable for transplant while also maintaining acceptable outcomes. So identifying those patients who have a lower risk of recurrent disease after transplant. So for the Milan criteria, that is a single tumor up to 5 centimeters or up to 3 tumors less than 3 centimeters. They can't have extrahepatic disease, so no METs, no major vessel involvement, so portal vein tumor thrombus. And we know the 5-year survival is pretty darn good, so 80%. The UCSF criteria, which is a newer criteria, that's a little more liberal with similar outcomes compared to the Milan criteria. So that takes a single tumor up to 6.5 centimeters or up to 3 tumors, the largest tumor being up to 4.5 centimeters. But the total tumor burden, regardless, has to be up to 8 centimeters, so nothing greater than that. Just like the Milan criteria, so they can't have extrahepatic disease, so no evidence of metastatic disease or major vessel involvement. So even if we're considering someone for transplant, we do pursue bridging liver-directed therapy or local regional therapy. This reduces the risk of waitlist dropout. As you can imagine, they're potentially going to be waiting at least 6 months to accrue those points and to be monitored their tumor biology. So if we go ahead and treat their tumor, they have a lower risk of progressive disease and waitlist dropout. And the choice of treatment is really based on the patient itself. So the individual tumor characteristics, their underlying degree of liver disease, and then the center's expertise. There was a recent UNOS analysis that suggested ablation or TARE may actually be a little bit better. So it's associated with a lower risk of waitlist dropout. So we don't typically use bridging systemic therapy. It's not recommended, although if it has been used, it doesn't preclude transplant eligibility. And then you'll hear us sometimes talking about downstaging patients. So patients who are otherwise transplant eligible, if their initial tumor burden is outside Milan criteria, we can consider transplant if we downstage them within criteria. And these are carefully selected patients. So again, they need that trial period of observation, at least 3 to 6 months of observation to allow us to monitor that tumor biology. If the AFP is significantly elevated, we must also downstage that. So we like it typically less than 500, but closer to normal is ideal. And then we know that post-transplant outcomes in those who have been successfully downstage, those carefully identified patients, there's no significant difference in outcomes. So surveillance imaging post-transplant for recurrence, we do that. So like I said, transplant, it doesn't come with an absolute guarantee that the cancer won't come back. Up to 15% of patients, even if they were transplanted within Milan criteria, will have recurrent disease. So we still surveil for it after transplant. The most common sites of recurrence after transplant are the lung, followed by the liver at 40 and 33%. So that's why you'll hear me talk about we surveil the chest as well. So the current guidelines, as you can imagine, like we talked about, we need good contrast enhanced imaging. So either a multiphasic CT or MRI, plus that chest CT scan we get to surveil. The optimal timing and duration of surveillance is not established, but we do use risk scores to tailor to individual risk and guide decision making based on the patient. So one of those risk scores is the risk estimation of tumor recurrence after transplant, or the retreat score, in those who had HCC meeting Milan. And things that are taken into account into that retreat score: so the AFP closest to the time of transplant, whether or not the tumor had microvascular invasion on explant, the number of viable tumors on explant. So even though we did liver local regional therapy before transplant, was there still viable tumor on the explant when we took that liver out? And then the size of any viable tumor that was there. So based on those things, we plug in the available information. It spits out a score. A higher score is a higher risk of recurrence, and that helps guide how often, for how long we do pursue surveillance imaging. Some sites follow other guidelines as well, like NCCN for following for surveillance, but at our center, we do follow the retreat score. So I think it's important just to mention as well, regardless, just discussing advanced care planning with patients. Not only are they likely to have advanced liver disease or decompensated liver disease, they have a malignancy as well. So regardless, it's just best to do advanced care planning, and it never hurts in some patients to engage palliative care just to assist with goals of care and help guide management as well, regardless of the outcome. Um, All right. So I know that was a beast. That was a lot of information that I tried to distill into 40 minutes. I could do a week-long talk on every single section. So hopefully I highlighted the pearls. I do find the ASLD guidance on HCC high yield. So if you wanted to go back and reference and go more in depth on any of the information that I talked about today, feel free to go there. And then special thanks to one of my interventional radiology colleagues at the VA, Dr. Rao, for helping me obtain all those cool photos for you guys. Just a plug on Dr. Kalra's, also his a conference that he's a chair for that's going to be in August, our Rocky Mountain Highlights in GI and Hepatology. So please go there and attend. We'd love to see you guys there. And thank you. What questions does everyone have?
Thanks, Ashley. Appreciate it. Can I ask a quick question?
Yeah.
So for the audience, I suppose, could you comment on, if in the community, on a surveillance ultrasound, a lesion is found, and then a CAT scan shows a cancer that's, maybe 1.7, 1.8 centimeters below, so below Milan criteria. How would you kind of advise folks to approach that situation? So you have a definite cancer that's below Milan, and in terms of deciding whether to wait or treat, how would you kind of counsel them? I know that's a call we get quite a bit.
That is an excellent question. So Dr. Kalra is alluding to a couple different things with this question that I think are high yield. So I think regardless of anyone diagnosed with HCC, to start off with, I would highly recommend they be referred to a transplant center to help assist with management and have access to the multidisciplinary team to guide decision making. Um, so we have pretty strict transplant criteria. Um, and it's very interesting. So patients with HCC, in order to be eligible for transplant, so meeting indications for transplant, getting those exception points, if someone has a solitary lesion that's above a centimeter but less than 2 centimeters, they technically don't meet criteria for transplant. We have to wait for it to grow to be 2 centimeters or above. So we typically, and someone who's otherwise transplant eligible, that we're thinking about pursuing transplant, we do not treat the lesion until it hits that 2 centimeter mark so that they do meet criteria for transplant. And then that option is available to them. So I would advise those GI providers and oncology teams in the community to refer those patients to us, as we will likely closely surveil them and wait for that tumor to grow if they're transplant eligible, rather than pursuing treatment.
Thank you. I think there's a question in the Q&A. I'll read it for you. It says, can isolated lung mets be effectively treated? And can patients with HCC and mets to the lung still benefit from transplant?
Yeah, very good question. Um, so in this situation, so it's a pre-transplant patient, I'm guessing. So someone with extrahepatic disease who hasn't been transplanted. So in those patients, we typically refer them to oncology for systemic therapy. As far as I know, I wouldn't think oncology or pulmonology would pursue specific local therapies for mets like we do for liver cancer. But for those patients, we would refer to oncology for systemic therapy. And we do see some improved outcomes in those patients, even though they have advanced disease.
Okay, I think that might be all the questions for now, but thanks again, Dr. Lane, for giving the talk. I think it was really helpful and practical, and I just want to mention again that in the chat is the link for the website. My advice would be for those of you listening live is just to open that link and save it on your computer or email, and then you can refer to this video later. You can look at the schedule, all the CME, maintenance of certification and nursing credit information is on there as well. And hope everybody has a great rest of your day. Dr. Lane, thank you again.
Thank you.